here. Russell is actually only 14 years old.
Wow.
He's always looked like he was 14 to me, you know. So I guess he grew this beard thing, so he, but anyway. Russell is a great PA. He graduated, when did you graduate? 2011. And works in neurology and has spent a lot of time with stroke, not only in Oklahoma, but in other states as well, as we were talking about. So we turn it over to him. So thank you for coming.
Yeah. Well, in regards to stroke recognition, a lot doesn't change. So the, as you can tell, the data is wrong. Some things have changed in intervention, and we'll talk about those. But so, why is stroke important? Well, this is why. I mean, it's no longer the second. It's the second leading cause of death worldwide, but in the United States, it's the fifth leading cause of death. But it's the #1 cause of adult disability. And sometimes this might sound morbid, but you're lucky if you land in this one, and you're less lucky if you land in this one. That's not always true, but sometimes it is. So nearly 800,000 new strokes per year. About 25% of those are repeat strokes, so patients that have had a stroke and they go on to have more strokes. So Oklahoma, we have the 4th highest rate of death due to stroke in the United States. So there's this area in the southeastern United States called the stroke belt. Oklahoma is actually not a part of the stroke belt if you look at the definition, but we do have a high rate of stroke. And if you pull up the most updated CDC map, it's really southern Oklahoma is very dark purple. I mean, we're purple throughout, which is the bad high rate of stroke death. They look at it as death rather than rate. So stroke definitions, types of different strokes. Stroke is a sudden onset of brain dysfunction related to a blood vessel abnormality. So it's a focal and it's abrupt in onset. Those things are important. Focal and abrupt in onset. You have 2 different types of stroke. So if you just say this patient had a stroke, you don't know that they have a bleeding stroke, a hemorrhagic stroke, or an ischemic stroke. Ischemic stroke is much more common than hemorrhagic stroke, 85% in the United States, and 15%. And that fluctuates. Sometimes is 87, 13. So these are just average numbers. So an ischemic stroke is loss of blood flow to an area of the brain. So focal area of brain leads to weakness, trouble with language, vision problems, depending on what part of the brain is affected, what blood vessels involved. Hemorrhagic stroke is a rupture of an intracranial vessel not due to trauma. We're not talking about subdural hemorrhages or traumatic subarachnoid hemorrhages. We're talking about primary hemorrhagic strokes. So 10% of all stroke is intracerebral hemorrhage. These are usually hypertensive. Subarachnoid is 5%, and this is usually due to a ruptured aneurysm. 80% of subarachnoid hemorrhages are due to aneurysm. So the most common cause of subarachnoid hemorrhage is aneurysm. Stroke, so these are the stroke types. Again, ischemic stroke, loss of blood flow, a blood clot either from the heart or from another blood vessel travels to the brain, or sometimes locally in that blood vessel, and you lose blood flow to the area downstream. The blood carries the glucose and the oxygen, so that tissue is deprived of that. The brain is very metabolically active. Bleeding into the brain, so most intracerebral hemorrhages are deep in the basal ganglia. You have these tiny little arteries. Over years, they get beat on by high blood pressure, and they become very fragile, and eventually they rupture. And then you got subarachnoid hemorrhage, so bleeding around the brain in the subarachnoid space. So a TIA, transient ischemic attack, this is a transient episode of neurological dysfunction caused by focal cerebral ischemia, and there's no evidence of a stroke on an MRI. Typically, these last less than 20 minutes. Occasionally, there's exceptions to this, and they can last a little longer. But the time duration is no longer part of the definition, and they're at increased risk for a stroke. Most of that risk is in the first 48 hours, but they look at it, but their risk of stroke over the next 3 months. But the biggest risk is in the next 48. That's why TIA is just as important to rapidly evaluate as a stroke is. So these are the types of ischemic strokes, and these are the etiologies of stroke, ischemic stroke. So it's broken down into 5 different categories. Okay, large artery atherosclerosis, so carotid stenosis or stenosis in the vertebral arteries. They can have intracranial plaque buildup that causes stenosis, or extracranial. Cardioembolism, the most common cause of cardioembolic stroke is AFib. And what we are seeing a lot of is paroxysmal AFib, so AFib that comes and goes. So just because they're not in AFib at the time that they come in with a stroke, doesn't mean that that's not the cause. And then if they've had a heart attack recently, and there's an area of the heart muscle that's weak, and the blood pools in that area because that part of the heart muscle is hypokinetic, not moving as well, or akinetic, then they can form a thrombus. Or if they have chronic heart failure. Small vessel occlusion. These are your lacunar strokes. These are the deep strokes that occur in the internal capsule due to the penetrating arteries off of the larger arteries, like the middle cerebral. Lenticulostriate is the name of those, off the middle cerebral. And these strokes are due to lipohyalinosis of these blood vessels. So these aren't like the clot forms in a big artery and travels to the next artery. These are local. Kind of the artery thickens over time and then completely closes off, and you lose blood flow to a small area of brain. And then stroke of other determined etiology, so a venous infarct. And then cryptogenic stroke, or stroke of undetermined etiology. So after doing a full stroke workup, looking at their heart, looking to see if they have AFib, looking at their blood vessels, you don't find a cause. And that's about 30 to 40% of strokes. And a lot of this group, about 25 to 30%, has paroxysmal AFib. So it's just, it hasn't been found yet. So lacunar stroke, these are those lenticulostriate arteries, right there. That's the middle cerebral artery, internal carotid. So these are your common lacunar syndromes. Y'all have access to this lecture, so I'm not going to bore you and read them, but usually a lacunar syndrome will be just hemiparesis, face, arm, and leg equally. And occasionally they'll have dysarthria as well if the face is weak. Or sometimes they'll just have pure numbness. So you've done neuroanatomy? Yes? So if somebody just comes in with numbness of the face, arm, and leg, what structure in the brain do you think would be causing those symptoms? Deep? That's the spinal cord. But in the brain.
Called central gyrus.
That's the cortex, yep.
Yeah. The pyramid.
The deep structure.
The internal capsule.
Medulla.
Close. Thalamus, there you go. That's one of the more common because it has tiny little arteries. Yeah.
It's just involved.
And then, so that's, it was right there, by the way.
Oh, no. Sorry, I don't know.
So, and then if you have it involving the thalamus and the internal capsule, you can have a thalamocapsular lacunar, and they'll have weakness and numbness. Face, arm, and leg. And then you can get unusual movements if it just involves the basal ganglia, usually the subthalamic nucleus. They can get a chorioathetosis that they can't control. So abrupt onset of this. Now, if this has been progressive over years, that's not a stroke. It's a neurodegenerative disorder. Does anyone know what that one is? That's a common cause. All right, so hemorrhagic stroke, so intracerebral hemorrhage, subarachnoid hemorrhage. Mortality at 1 year is 55%. These are bad strokes to have. People are very disabled from them and they have a high mortality. And only about 20% are independent at 6 months. Causes, hypertension is the #1 cause. Amyloid angiopathy. So amyloid angiopathy is a condition that you see usually in patients 60s, 70s, older patients that have what are called microbleeds on their MRI. And it's usually associated with dementia, usually of the Alzheimer's type. And amyloid is a protein that deposits in the blood vessel wall that leads to the little tiny microbleeds. They can have a large, what we call lobar hemorrhage. Ischemic stroke with hemorrhagic transformation, venous infarcts with secondary hemorrhage. So one of the sinuses gets a clot. Certain coagulopathies, so if they're on Coumadin or other blood thinners. And if they have liver disease, that increases their INR. But the interesting about liver disease is they're also hypercoagulable. So it's a very hard situation to manage if they have cirrhosis. AVM, so abnormal blood vessel, arteriovenous malformation, and then illicit drug use, cocaine being the most common. But meth in Oklahoma, you can't afford cocaine. So, the presentation of an intracerebral hemorrhage is what differentiates it occasionally from an ischemic stroke that is helpful. Really, you need a CAT scan, but it's helpful is if they have abrupt onset of headache and vomiting. And that's due to the rapid increase in intracranial pressure from the hemorrhage. And they usually have altered level of consciousness, so decreased level of consciousness. How do we clinically grade level of consciousness?
The coma scale.
Have you heard of the Glasgow coma scale?
Yeah.
Did you see? So depending on the area of the bleeding, depends on, it can have different symptoms. If it's in the internal capsule, basal ganglia, they'll have a hemiparesis. If it's in the cerebellum, they'll be ataxic. They can occasionally have a seizure, especially if it involves the cortex. And then their blood pressure is usually elevated, likely because they have chronic hypertension, but also the stroke itself is making the blood pressure elevated due to the increased intracranial pressure. Subarachnoid hemorrhage. The most important thing about a subarachnoid hemorrhage is the worst sudden onset of the worst headache of my life. Anyone in here have migraines? So, the migraines are terrible, but they gradually worsen over 5, 20 minutes, sometimes longer. So, they're different. So, migraines can be, the worst headache of my life, but it won't be sudden in onset. They may transiently have altered consciousness. Ruptured aneurysm is the most common cause of a spontaneous subarachnoid hemorrhage. Again, 80% are related to aneurysm. CT scan is negative in 2 to 4% of patients with subarachnoid hemorrhage. The mortality is about 38% at 1 year. So slightly less than intracerebral hemorrhage. So stroke recognition. So the target you want to get, if a patient comes into the emergency room and is having a stroke, it's important to get a rapid history and a rapid exam to do things quickly. It's kind of the code blue of the brain. Because everything that we can do to treat an ischemic stroke, time is the most important. So sudden onset of symptoms, you want to establish that, usually reaching their maximal intensity all at once. There are risk factors: diabetes, high blood pressure, history of heart disease, hyperlipidemia, AFib, tobacco abuse. And then if the patient is able to tell you and they're aware of their symptoms, you can ask, what was the exact time that the symptoms started? But if it wasn't witnessed and the patient's not able to tell you because they have aphasia, trouble talking, communicating, or they're not even aware of their own deficits, then it's time last known normal, or they seen by somebody else. So sudden onset is very important when it comes to stroke. So it's a strong predictor of stroke diagnosis. So the mental status, checking their language, asking them to name objects. What's on my wrist? What is this called? Hold a pen, hold your glasses, have them name simple objects that an everyday person could name. Look at their strength, so see if they can hold their arm up in the air. Check their hand strength. Usually the hand is more effective than the proximal muscles. If they don't drift down, but they're saying they have weakness, you can check the hand, see how strong they are. And a better way to check it, a lot of people walk up and say, squeeze my fingers, squeeze them, try and break them. But a better way to do that is to have them spread their fingers and try and push them together. So don't let me push. So that's a little more sensitive finding. Because we're not good at telling if people have hand grip, and also they can just lightly grip and you don't know if they're really trying. Look at their visual fields. So check the visual fields and their gaze preference. So are their eyes pointed one way or the other? And they're not really looking to the other side. So patients like to look with cortical involvement, so a left MCA stroke or a right MCA stroke, they look at the stroke. And that's due to the frontal eye fields being damaged. And then visual fields, you just hold up 1, 2, or 5 fingers and you have them, I'm going to use you, so you just say, look at my nose. I'm going to hold up 1, 2, or 5 fingers. You won't be able to see them directly because you'll be looking here at me. You hold up how many?
1.
Yep, good. You check all the quadrants. Good. Then, so you got to get all the quadrants. You don't have to have them cover their eye or anything like that for stroke evaluation, unless the vision loss is monocular, meaning it's involving one eye. Sensation. So the best way to assess sensation is to just take your finger and barely touch. I'm going to either touch right, left, or both. Now you close your eyes. Tell me if I'm touching right, left, or both.
Right.
Good. Good. You can also, if you have a safety pin, you can use that. Just don't stab them. Like, we're just looking for obvious things. Coordination, so you check their finger to nose. Have them touch their nose and your finger. And then the heel to shin. Have them run their heel up and down. So you're looking for lateralizing deficits, meaning one-sided symptoms. So their level of consciousness, this is from the NIH Stroke Scale. So are they alert and oriented? Are they attentive? Are they somewhat drowsy? Or obtunded? Or are they in a coma? They're not really responding at all. So with an acute ischemic stroke, usually you don't see a decreased level of consciousness. That's not always, there's always exceptions to a rule. But in general, that would suggest more of a hemorrhagic stroke or some other etiology. It's causing the patient to be more sleepy. But if it's involving both hemispheres or certain parts of the brain stem, then they can have decreased level of consciousness. Language, so checking for aphasia, which is can they repeat and understand? So you tell them to repeat a simple phrase, give that dirty dog a bath, no ifs, ands, or buts. It's a sunny day in Oklahoma City, you know, something like that. Dysarthria, you're looking at their articulation. So aphasia, our ER residents at our hospital struggle with this. I don't understand why, but they do. But aphasia is a language problem. Dysarthria is an articulation problem. This is very localizing. This is not localizing. Dysarthria can be a symptom of stroke, but in isolation, that would be unusual. But we can all make our speech slurred, right? I'm sure y'all did it this past weekend. You're good students. So, orientation. Again, we mentioned that. She said alert and oriented times 3. Person, place, year, month. So assess the face. Ask the patient to smile. See if their smile is symmetric. Do they have a facial droop on one side? Again, have the patient hold both arms up. If they're obtunded and kind of sleepy and not responding, what I do is I pinch the inside of their ear and see if they withdraw or localize to the pain. So weakness, again, is another predictor of a stroke diagnosis. Abrupt onset of focal weakness, so right hemiparesis, either involving or a monoparesis in the abrupt onset of the arm or the leg. So visual fields, we did that. And then the gaze deviation. So hemianopsia, so loss of vision. So she couldn't count the fingers on the right side, but was able to do it on the left. That's a good, strong predictor of stroke. That's called a hemianopia. And then the gaze deviation, then looking to one side, not really looking over here, even though you're standing on the left side and they're just talking this way. So it will usually be opposite the weak side of their body. So they'll be looking at the stroke. So somebody with a right hemispheric stroke or a right frontal lobe involvement will be looking towards the right, and vice versa to the left. Light touch, we did that. And why I do both at the same time is you're looking for neglect. So they feel it when you do them individually, but then they ignore the left side when you do them both at the same time. Testing for ataxia, the finger to nose, the heel to shin. So in cerebellar strokes, one of the more common findings on their exam is going to be ataxia. But the abrupt onset of vertigo, so the room spinning and trouble walking, is kind of the historical factor of a cerebellar stroke. Because a patient with like a midline cerebellar stroke, so in the vermis, they may not have limb ataxia, but they can't walk. And then usually they'll have nystagmus as well. So we talked about this. Look toward the cerebral lesion, but in the brainstem, they look away from the lesion. So they'll be looking at their weakness in a brain stim. And then seizure also. They'll look at the side that's jerking. You can check doll's eyes. So if they have a forced gaze deviation. If it's involving the frontal lobe, you should be able to overcome the gaze with doll's eyes. But if it's involving the brainstem, you won't be able to get there overcome it. Pupils, it's important to look at, but usually not that relevant in stroke. It is relevant if they have a decreased level of consciousness. So if someone is not responding, they don't seem to be moving their right side, and their left pupil is blown and doesn't react to light, then they have a left hemispheric lesion and they're herniating on the left side of their brain. So again, if the patient's obtunded, not responding, you can check painful stimuli to see if they localize to it or move or if they grimace. And then looking for the presence of a Babinski. Do we know what a Babinski is? Scrape that lateral aspect of the foot slowly and come across towards the big toe. And that's an upper motor neuron sign. So it's non-specific. That could be due to spinal cord disease. That could be due to brain disease. They could have a mild cerebral palsy that's from an old injury when they were babies. So sometimes after patients have had a generalized seizure, they'll have a Babinski transiently and then it will go away the next day. So the National Institute of Health Stroke Scale, this is a standardized scale. It has a score of 0 to 42. And you check these 11 items that we just went through. So level of consciousness. There's 2 questions on there. How old are you? What's the month? Are they awake and alert? And they get points for those things. Their gaze, do they have a gaze deviation to the right or to the left? Are they able to look laterally? Visual fields, checking for a visual field deficit. Smile. Do they have facial asymmetry? Another trick is to look at the nasolabial fold, those asymmetric. So mild facial weakness, they may only just have a subtle flattening of that. And then arm strength, can they hold their arm up? So you have them hold their arm up for a count of 10 on each side. Look for a drift. And same thing with the legs, but only for a count of 5. And then the ataxia, finger to nose, heel to shin. Then you check sensation in their face, their arm, and their leg. You always, for stroke patients that you're just rapidly evaluating using this scale. So if you think somebody's having a stroke, this is your neurological exam in the emergency room. This is for sensation. Really, you just need to check proximally because some people have neuropathy or some other reason why they can't feel, and it's unrelated to the stroke. So you always want to check proximally. And light touch, like I just did with my fingers, is good enough. Now, if you have access or you have a little sharp object that won't break the patient's skin, you can use that as well. Or you can use something cold, like a cold tuning fork. Language, so there's pictures that are part of the NIH Stroke Scale that are in the packet. That you have them named, but you can also just ask them to name your watch, the watch band, your glasses, a pin, a button on your shirt, the collar of your shirt, just things that patients would know what, and then have them repeat sentences for you, and then there's several sentences on the NIH Stroke Scale that you can have them read. And then just as you're talking to them, listening for slurred speech. So is their speech slurred? And then the extinction and inattention. So they're ignoring one side. So when you do visual fields or when you do sensation. So when you get good at this, you can do this in like 2 minutes. And it's important to be able to do this quickly. So here's the scale and how they're graded. So sudden onset, you see that term a lot, right? Of focal neurological symptoms, usually maximal at onset. And then, does it fit with a vascular territory? So the cortex or the subcortex, does it seem like a brainstem or a cerebellar stroke? You know, you can have weakness with all of these. Well, all of these except the cerebellum doesn't cause weakness, it causes clumsiness or ataxia. Usually with brainstem lesions, they'll have a cranial nerve finding. They'll have double vision or dysconjugate gaze. They'll have numbness on the left side of their face, but then they have numbness on the right side of their body. And they have vertigo as well with it. Those are all symptoms of posterior circulation. So left hemisphere and right hemisphere, so we'll talk about those. So the stroke syndromes, if they're having a dominant hemisphere stroke, usually left, then they'll have language problems, so the aphasia, and then they'll be weak in their face, in their arm, and sometimes leg, but usually if it's MCA, the face and the arm are going to be much more severe than the leg. You remember your motor homunculus, the legs at the top? That's supplied by the ACA artery, okay? And then all the fibers from the cortex go down into the internal capsule. The fibers go down, so if the MCA stroke is large enough, and they have leg weakness, that means they're having a very large stroke because it's involving the deeper structures. And then if it's non-dominant hemisphere, then they'll be neglectful of the left side, and they can have what's called a nosa agnosia, which is they have no insight into their deficits. And I know that term was probably mentioned in neuroanatomy, I'm sure. Does that sound familiar?
What is it?
A nosa agnosia. Lack of insight to one's. All right, brainstem. So usually contralateral hemiplegia with an ipsilateral cranial nerve deficit, double vision, slurred speech, or other symptoms. Vertigo is common. It's involved in the vestibular nucleus or the cerebellum. So meaning they have a third nerve palsy in their left eye, but they're clumsy with their right arm. So that's what I mean by crossed. See, ipsilateral, so that would be a left brainstem stroke in the midbrain, involving the left cranial nerve 3, and then it's hitting the motor tracts. So they're above the level of decussation in the medulla, so it still involves the opposite side. Crossed findings are on every board exam I've ever taken. So they love that question. Cerebellar, common symptoms, balance, and unilateral coordination difficulties. Balance meaning trouble walking. So they fall to one side, they can't walk on their own, but they were walking 2 hours ago. So abrupt onset of difficulty walking. Hemorrhage, so usually again, headache and nausea, vomiting, decreased LOC, that's what differentiates from an ischemic stroke in most cases. Again, you need a CAT scan. A CAT scan will tell you if it's hemorrhage. And then intracerebral hemorrhage, yes, sorry.
So with the ipsilateral cranial nerve deficit, would that count the trochlear nerve that crosses?
You're not going to see a trochlear nerve on a physical exam, to be honest with you, but that's an exception. But yeah, they will have double vision, and usually that nerve, when that nerve is involved, it's not that their eyes will look like they move very well, because there's so much overlap. But then when they look down to read is when they have their double vision. That's a good question. And then subarachnoid hemorrhage, so is neck stiffness and pain, light intolerance. What else causes neck stiffness and pain and light intolerance?
Meningitis.
Yeah. What do you call neck stiffness and pain? What's the clinical term for that? Good job. All right. So, case number 1. This is a 62-year-old female with an unremarkable past medical history presented to the emergency department at noon following a sudden onset of left-sided weakness, left hemiparesis. Exam on arrival, moderate left hemiparesis, left hemisensory loss with neglect, left hemianopsia, and a right gaze preference. Where is her stroke?
Right side.
Right side. Do what?
Above the neck, so it's
Yeah.
across the lung.
And what, so is that the right side of the brain stem? Is it the right
Hemisphere.
hemisphere? And how do you know that?
Both brain stems would be.
Gaze preference is a clue, so that's what lobe? What lobe is involved? No? So gaze preference is just their eyes are over. Frontal?
Frontal.
Yes. So the frontal, yeah, frontal lobe is involved. So what lobe is involved for this? I'm sorry? Yeah, the tracks go to occipital, but it's MCA that supply the occipital lobe, PCA does, but it's the temporal lobe. So the fibers that run through there. And the neglect, that's the right parietal lobe. And then left hemiparesis is again the prefrontal gyrus. Right hemisphere. See, y'all knew more than what the question asked for. So stroke treatment, we now have 2 treatments available for patients if they present within a certain time frame. For this, 4.5 hours. So needle to vein with medicine going in vein by 4.5 hours. Not, they show up into the ER at 4 hours and 20 minutes. You're likely not going to have enough time to fully evaluate. The needle to vein, 4.5 hours. The FDA, I will say, is in this drug IVTPA, they're actually wanting us to get away from using TPA. They want us to call it Altaplace, which is the generic name for it, because of medical errors in charting. So, just a side note. But the FDA has it only approved for up to 3 hours. But the American Heart, American Stroke Association, it's approved up to 4.5. It's just the company didn't want to pay for the double-blind randomized prospective trial to prove that it works at 4.5 hours. So those trials cost a lot of money. Endovascular therapy. So this is a neurointerventionalist or a neurosurgeon with endovascular training. Goes in through the groin, threads a catheter up, and actually goes and removes the clot. And then medical management is important, control of blood pressure, glucose, making sure they're perfused appropriately. So stroke is a medical emergency, time lost, is brain loss. So every minute treatment is delayed, 2 million neurons are dying. And every 15 minutes, the delay of treatment, it decreases the likelihood that the patient will be walking at 6 months. So this area we're trying to save in most stroke cases is the penumbra. So this is the area of the brain that is shocked and losing blood flow, but can be reversed. So this is dead tissue. This is irreversible. So the penumbra is what we're trying to save here by pulling out this clot here. And if they get to the ER quickly enough, they get treatment quickly enough, they call it the golden hour. So if you treat a stroke within an hour of symptom onset, a lot of time you can reverse everything. I mean, they don't have to be dead tissue. But the longer there's delay in treatment, the larger this becomes and the smaller this becomes. So penumbra is the zone of reversible ischemia around the core of infarct. It's salvageable. It's damaged by hypoperfusion, meaning, their blood pressure is 160 over 105, and then let's give them clonidine, even though they're having a stroke, and you don't want to do that. So if somebody's having a stroke, you let their blood pressure stay high. If they're not a candidate for TPA or true thrombolysis, then you let it be as high as 220. And that's on slides later on. And then if they are a treatment, you want to get it down below 185. So hyperglycemia, keeping blood sugar, usually the goal is keeping it between about 100 to 180. You also don't want hypoglycemia. And then fever and seizures. So patient comes into the ER, what do? We look at their, make sure they have circulation, so their pulse is important. Make sure their airway is protected, make sure they're breathing. These are all general important things. I know it's not the ABCs anymore, but it's CAP. So intubate if needed. So if they're unresponsive and their O2 saturation is dropping. Fluids, giving them normal saline to improve perfusion. Do a quick neuro exam. And then the diagnostic studies, the CAT scan. Checking a blood sugar, sending off blood work, getting the CAT scan is the most important thing quickly. History exam, CAT scan. If you think they're having a stroke. EKG, you can do that after everything's been decided, unless you're worried about a cardiac problem. Same thing here, if they're on Coumadin, these things you want to check this as well. But you don't wait on the lab results to give TPA unless you have a clinical suspicion. So CT scan, it's very quick. It takes like 2 minutes to do. It tells you if they've had a hemorrhagic stroke. So a clinical exam alone, you can't see a patient. That's why if someone in front of you is having, say on campus, you see someone and you think they're having a stroke, you don't give them an aspirin because you don't know if they're bleeding into their brain or if they're having an ischemic stroke, even though it happens all the time. Because that's what we do for heart attacks, right? People are having a heart attack here, take aspirin. And then also, if they're having a stroke and they're weak, they may not be able to swallow very well. So, the guy had a patient this past week. He was eating McDonald's with his brother and developed weakness, and there were some highway patrolmen there, and they gave him aspirin and nitroglycerin for his stroke. Yeah, that works for heart disease. Bad for brain. So CT 101, or the 50 Shades of Gray. So different tissues within the brain have varying densities and absorb X-rays. So there'll be various shades of gray. The basal ganglia are darker, the gray matter is dark, and the white matter shows up a little lighter. Bone has the highest density, so it's bright white. Blood has high density, so it's bright white. And then these are graded by Hounsfield units. So the higher the density, the higher the Hounsfield unit. Contrast is bright. It allows us to look at the blood vessels. Hemorrhage is obviously bright white, so that's kind of what you're looking for. And then normal brain tissue has an intermediate density. So hypodense tissue can be, this is how a stroke shows up on a CAT scan. But if a patient comes in and they're in less than 6 hours, you wouldn't expect to see the stroke on a CAT scan. You're doing this CAT scan to rule out bleeding. So it takes about 6 hours, up to even 24. And then CAT scan is only 60% sensitive for brainstem strokes. Why is that? It's because the skull is thicker, the occipital region, the brainstem sits below it, so there's a lot of artifact. The x-rays have to penetrate a higher density to get to it. So the posterior fossa CAT scan is not the best test for it. We'll find hemorrhages though, that's what we're looking for acutely. But MRI is a much better test to look at actual brain. So CT scan, it's fast. It's almost in every hospital. There's no reasons to not get a CAT scan. No contraindications to that. It does give you a nice picture of the bone for like trauma. Very high sensitivity for hemorrhage. 100% for ICH. 90% for subarachnoid hemorrhage. Modern day CAT scans are higher than that. That's what I deal with on the test. Disadvantages: poor for evaluating the posterior fossa. We talked about that. Thick skull, back. Poor sensitivity, and then identifying early ischemic changes. So remember this: a normal CT scan. So your patient comes in, and an hour ago their symptoms started. Just because they have a normal CT scan, oh, you're not having a stroke. You're crazy. We're going to send you to the psych ward. That does happen. Left hemispheric stroke. So you can see. I hit these lights, will turn them all off. There we go. So you can see a little better now. See how hypodense? So this is normal brain tissue, the cortical ribbon. You can see the basal ganglia. So this is a very large left MCA stroke. So this stroke is probably more than 24 hours old because there's some areas here of petechial hemorrhage, which is kind of normal for a large stroke. See a little bit of bleeding. This is the right basal ganglia hypodensity. See, you look over here, nice. See the basal, the head of the caudate, internal capsule, basal ganglia, thalamus. Very matter. And over here you see a big chunk. This is the cerebellum, vermis. It's part of the midbrain. Occipital lobes, frontal. What are these? Early stroke, yeah, so I'd say this is probably somewhere between 8 and 12 hours old. This is a hemorrhage, see how easy, it's almost as bright as the bone. Left basal ganglia. Frontal lobe, this is what I called, earlier I used the term lobar hemorrhage, lobar. An older patient, we would suspect amyloid angiopathy for this. This could be venous infarct with hemorrhagic transformation. Yes, it could be like ruptured AVM. This is, again, this is, see, basal ganglia, this is going to be due to hypertension. So 2 hours, 6.5 hours. Usually, if somebody comes in with a hemorrhage, we repeat the CAT scan about 6 hours later to see if it's grown. And then you see this. This is blood in the ventricles. So this is not going to be a survivable bleed patient. I mean, going in, they're doing trials right now on certain surgeries to see if they help, but they aren't very promising. This is what subarachnoid hemorrhage looks like. Kind of looks like a little crab or a frog, little legs. But This is in the subarachnoid space. See how different that looks than this? And this, and that, very different. And then kind of diffusely hyperdense, I'd expect. So he's not getting, he or she is not getting good perfusion. General management of subarachnoid hemorrhage. Ultimate treatment is to try and clip, coil the aneurysm to stabilize it. That's done by either a neurosurgeon or a neurointerventionalist. Blood pressure control. Maintain hydration, keep them euvolemic. Nemotop is a type of calcium channel blocker that kind of helps with vasospasm. It helps to treat vasospasm. It does not prevent vasospasm. MRI, it uses magnets, shakes around hydrogen ions, radio waves, and then it gives us a very pretty picture. Low signal intensity lesions are dark, high signal intensity lesions are bright. No radiation. It's very sensitive to ischemic stroke, depending on the size of the stroke, and these things 5 minutes. The symptoms an MRI can be positive. They can show the old strokes. Better look at the entire brain, posterior fossa, that we talked about. So MRI is kind of better for soft tissues, where X-ray is better for hard bones. Problem is not everybody can have an MRI. They have a pacemaker, bladder stimulator, spine stimulator for their chronic pain. Most bladder stimulators we can do MRIs on now. They're doing studies at Johns Hopkins and the Mayo Clinic looking at being able to MRI brains in people with pacemakers. Most of it is titanium, which is non-magnetic. And you get phone calls all the time. Another hospital calls us. Sometimes it's a doctor, sometimes it's another PA, sometimes it's a nurse practitioner, whatever. But they say, oh, they have a joint replacement. Okay, orthopedic metal is titanium, and it's been that way for a long time. We can MRI it. Now, if they've had a gunshot wound and you don't know what type of gun it was, they have retained bullet fragments that are in dangerous areas, like maybe still in the stomach or something like that. The abdominal cavity, you may not be able to MRI them, but most bullets are lead. So if you know the type of gun, you can figure that out. But orthopedic procedures are not a contraindication to MRI. Spine surgery. Sorry, it's not they take longer to do, so an MRI of the brain, so a CAT scan takes like literally 20 seconds. And it takes more to get the patient onto the table and the gantry and pressing buttons to actually get the CAT scan. The total time maybe 5 minutes for all that. MRI, a brain without contrast, patient's staying still, and you have a good MRI machine, you can get it done in about 20 minutes. But most MRIs, it's probably 30 minutes. So these are MRI findings of acute ischemic stroke. This is called diffusion-weighted imaging. So restricted diffusion is what this is, this bright spot. What that is that the hydrogen ions in this area aren't moving. So it shows up, the MRI gives us a picture of a bright spot, and then on this is kind of when you get this imaging, you automatically get this one. This is kind of the opposite of it, that shows up dark. So occasionally you can have these bright spots on the flare imaging, have what we call T2, we call it T2 shine through, where they'll show up kind of bright on this DWI, but they'll be bright. See how this stuff is bright here? right here. You see that? And so sometimes it will show up a little right here. That's called T2 shine through. So other things that can cause restricted diffusion in this area that's clearly a stroke is based on the location of it, but occasionally abscesses and certain types of brain tumor can also show up right. This is one of those microbleeds I mentioned earlier with amyloid angiopathy. So this is called GRE. This is just a sequence of MRI. Some places it's called T2 star. And it's just the physics of how it moves those hydrogen ions. This is another, so when it's deep in the basal ganglia, well, here's the basal ganglia, this is probably the top. Then this is likely from hypertension, or it could be what's called a cavernoma, which is a benign blood vessel abnormality. And then also things that are calcified will show up dark on the gradient of the T2 star. So medical management of ICH, your ABCs are going to be more important. More patients with ICH end up intubated. They have more decreased level of consciousness. Medical management, you want to target blood pressure of less than, some institutions, it's very controversial right now, but some institutions do 140, some do 160. It kind of is, it depends on the size of the hemorrhage and location. And there's a lot of factors that go into this, but no higher than 160 for sure. Treat hypothermia, so fevers, Tylenol, cooling blankets if needed. Glycemic control, again, keeping that glucose in between 100 to 180. If they are on Coumadin or they have bad cirrhosis, then you'll want to try and correct the sign R. How do you correct it? You know how to correct it if somebody's on Coumadin?
Vitamin K.
Vitamin K. That takes 24 hours to work, so what you give them immediately is you try and replace those clotting factors. You give them the vitamin K, and you try and reverse those clotting factors, or give them additional clotting factors, like fresh frozen plasma, or what name of the product. They don't need steroids, and then preventing pneumonia, preventing other complications from the hemorrhage. Acute ischemic stroke intervention, so optimize cerebral perfusion, oxygenation, their temperature control, glucose, permissive hypertension, and try and restore blood flow if you're able to. So IV TPA up to 4.5 hours. We can do this now up to 24 hours, depending on certain imaging that we haven't talked about here, but that just recently happened. The Diffuse 3 and the Dawn trial came out earlier this year, and you can treat certain patients so they can do perfusion imaging, which looks and gives you a nice pretty picture of what the blood flow is like, so it tells you about that core infarct and the penumbra. So if the penumbra is significantly larger than the core infarct, but they woke up with symptoms, now we can still treat these patients where before people were treating them occasionally if their CAT scan looked good, but now there's some science or some evidence for that. So you don't treat the blood pressure unless it exceeds your goals. So avoid hyperglycemia. Use normal saline and IV. Only give them glucose if they're hypoglycemic. The head of the bed should be anywhere from 0 to 15 degrees, depending on their level of consciousness, depending on how well they're breathing, depending if they're having trouble with secretions. Give them supplemental oxygen, keep their O2 sat above 94, and then treat fevers. So restoring blood flow. With the NIH trial, this was the trial that allowed us to start using Activase or Alteplase. Activase is the brand name. Alteplase is the generic. TPA, tissue plasminogen activator. So this was looking at patients treated within 3 hours and compared IV TPA to placebo. Symptomatic hemorrhage was 6.4% in the TPA group, 0.6 in the placebo. And then how they graded this was any type of neurological deterioration and a spot of blood on their CT scan. So depending on your definition. Because some people consider a symptomatic hemorrhage only if their NIH Stroke Scale score increases greater than 4 and they have hemorrhage on the CAT scan, hemorrhagic transformation. When they looked back at this trial with those criteria, only about 2 to 3% of patients had bleeding, like 2.5. And that is the definition for the SITS most and the ECAS. SITS most and the ECAS European trial 2. So IV TPA is the gold standard for less than 3 hours. If you think they're having a stroke, and it decreased their disability risk by 30% at 3 months. So it's the only FDA-approved medication. 3 hours, within 3 hours, but you can treat almost all patients up to 4.5 hours with IV TPA. They have a very large occlusion. It's not as effective. This is usually better for smaller strokes, so branch occlusions off the M1. But it's still the best treatment. It's just less effective. It recanalizes the vessel if it's a proximal M1 or ICA. It recanalizes the vessel about 12 to 13% of the time, where if it's a smaller branch, it recanalizes the vessel about 40%. So treatment rate was only 7% in 2011. These are the exclusion criteria. So in 2015, this was when endovascular therapy had proven to be of benefit. And they say it's about time because they've been looking into this for multiple trials failed before this. So now it's class 1 level of evidence A, recommendation up to 6 hours. But again, that's actually been extended more recently. But again, it involves it involves technology that not every hospital has, the perfusion imaging. That's why I didn't really put it in here a lot, but I just kind of want y'all to know that. It definitely is. Treatment guidelines are based on 5 recent clinical trials that showed significant benefit of EDT in treating large vessel occlusions, all the way up to M2. So this is the device they use. So here's the clot. You thread the catheter up, thread the catheter past it, open up. This is a stent. It allows the blood clot to go in, and then you pull the blood clot out. And then you squirt contrast into that artery and see how well it perfuses, and if all the blood vessels are open, and sometimes you have to repeat this several times. And you don't leave the stent in. The stent comes out. So these are the patients that had functional independence at 90 days in the endovascular trial, these 5 trials. This was the first one to come out, Mr. Clean, that year. And so this is the TPA only, and this is endovascular. So here, greater than 70%, 60%, 45%, 35%. So this is the include, they need to be age greater than 18, NIH Stroke Scale score was greater than 6, and they needed it in the groin puncture within 6 hours. So 6, 6, 6. And then they needed to document the large vessel occlusion, so distal ICA or approximate MCA, which is usually M1, M2, occasionally M3. So here's just the breakdown: internal carotid artery, as it comes in cranially now, about right here. Then you have the M1 and the ACA, and here communicating with distal M1, M2, and then M3, being up a little higher. So this is what's called a dense MCA artery sign. So you got your CAT scan, right hemisphere, left hemisphere. So it's like you're looking at somebody lying in front of you. Have you done radiology, or is that just a part of each? So, but this artery is lit up. This is where the MCA is. So they have a big old clot. They have a big clot there. There it is. Any questions?
Would you still consider giving IV TPA to elderly patients post 3 hours? I think we were told that for the elderly, the cutoff is like a hard 3 hours, and younger patients you can kind of extend that.
No, that was, they initially made that a part of the guidelines, but that's been taken off.
Okay.
So age is not a reason. It's, you weigh the benefits and the risks more. So the number needed to treat to have a good outcome at the 3 hours is 10. So you need to treat 10 patients to have a good functional outcome. And the number needed to treat in the 3 to 4.5 hour window is 20. So you're not making as much benefit. So if somebody's having, you know, a very big stroke, the TPA is unlikely to help them and is more likely to harm them, and you know they're older and these things, then yeah, you may not do it. That's kind of a case to case. So it's not, there's not a straight answer for that, but
Yeah.
age is not a reason to not give it. There has to be more to it than that. But that's a very good question. Commonly comes up every day. Any other questions? Or? I guess we'll take like a 5-10 minute break, and I have a few case presentations that we'll try and get through. I like the light on better.
That's not a new thing.
You don't?
What's freaking you out? Did you think I like that. Consistently worried my butt's gonna end up in the video.
Right. Yeah, I think so. My daughter was just like, or no, she's been trying to pull it up, but it's not in the shower again.
Yes.
Like me and your internet just goes out. It was left.
It says 19 minutes left. Just, it's going down. I don't either.
Like 14 minutes, she says it's before she comes in.
Well, yeah.
I missed one practicing.
Yeah. On who?
Let's see. How I
Look at that, 25 minutes.
Okay.
That came from headache. Yeah. That
Just like
not
one day a week.
abrupt onset of focal deficit, like an ischemic stroke, but they will commonly, like if they have headache involvement, that's highly suggestive. It's cerebral pain, it really will work their calcium, blood, or something like that. But if they have a posterior spinal stroke, they probably do have headache vomiting as well. They're ischemic stroke, so it doesn't mean that it's just if it happens. It's just
What he was saying about, yeah, I look toward the stroke, right?
Yeah, I wonder if I'm getting this. Okay, so if I have a face here, and the lesion is right there, that way. But it's different depending on what the, like if it's cerebellar versus cerebral.
I think it depends on.
Well, let's say he says you're looking towards the stroke, so you would be looking that way. But is
Then
this side of the face messed up?
Yes, I think the opposite side.
Okay, so like this side's drooping.
Yeah, exactly.
That's what I was like,
Yeah, because it's above the diffusion point. But I don't know why his eyes look toward it, but that part I don't quite understand.
yeah, I just wasn't sure if I was getting that right. Like,
That's what I got from it. So hopefully. I downloaded. Okay, so it's
Seizure